It's Dr. Amrita Basu from University of California, San Francisco, presenting our fourth lecture on identification of symptoms that are associated with IRAEs in the I-SPY clinical trial.
On behalf of the I-SPY 2 investigators, I would like to thank the program organizers for the opportunity to present our data on the identifications of symptoms associated with immune-related adverse events in the I-SPY trial. Immune checkpoint inhibitors were first introduced in the metastatic breast cancer setting with improved outcome in PD-L1 positive disease. The checkpoint inhibitor pembrolizumab is now approved as standard neoadjuvant therapy for high-risk, early-stage triple-negative breast cancer, with improvements in both response and event-free survival. However, the benefit of these immune checkpoint inhibitors comes with a higher frequency of immune-related adverse events, some of which are irreversible. These include hypothyroidism, adrenal insufficiency, and diabetes. IRAEs can affect any organ in the body. Checkpoint inhibitors given with chemo in the neoadjuvant setting can be associated with multiple immune toxicities, and this include rash, thyroid dysfunction, and adrenal insufficiency. Combination therapy results in many early symptoms, which may be harbingers of an IRAE. We wanted to predict which patients are at risk for developing a serious IRAE to enable early consideration of optimal treatment choices. In addition, we wanted to understand which symptoms during treatment most contributed to impairment in overall quality of life. In order to think about the balance between toxicity and efficacy, we are developing a standardized method to predict immunotherapy toxicities to assist patients and providers in decision-making. And to do this, we are incorporating side effect burden, duration of side effect and persistence, and quality of life. And we want patients to be where the green circle lies on the plot to the right, where patients achieve excellent efficacy rates and maintain a good quality of life. We analyzed data from the neoadjuvant phase 2 I-SPY 2 trial that includes patients with early-stage high-risk breast cancer. One of the goals of the I-SPY 2 trial has been to minimize toxicity in the investigational drugs that we select to be on the trial. In I-SPY, we collect adverse event information at multiple time points through treatment and continuing through follow-up. In April of 2021, we also started collecting patient-reported outcomes for all patients enrolled in the trial. So our data set includes the following assessments. We included clinician-assessed adverse events. We included all grade 1 through 4 AEs. These were collected weekly to every 2 to 3 weeks, depending on chemotherapy schedule. And we followed patients up to 1 year. We also collect patient-reported outcomes. The instruments we used include Pro-CTCAE, this is a collection of symptomatic adverse events, and PROMIS, an instrument to collect quality of life. And we collected this information for 8 functional domains. Patients filled in at least 2 time points, including baseline, and surveys were collected weekly for symptoms and monthly for quality of life. These surveys were collected through 24 months, and they were reported using the Likert scale between 1 through 5. Our study population included 482 patients that were prescribed at least 4 doses of immunotherapy in combination with chemotherapy. And we had 346 patients in our patient-reported outcome cohort with a survey completion rate of 72% and a 20% overlap with CTCAE. The IRAEs that we included in the data analysis included hypothyroidism, adrenal insufficiency, pneumonitis, and colitis. And we looked at whether age and race were associated with any of the 4 IRAEs. Pneumonitis rates were higher in patients over 50 than under 50. No other significant associations were observed. Next, we analyzed the time to IRAEs and evaluated the cumulative incidence of IRAEs over time. As shown, adrenal insufficiency in black appears later than other adverse events, such as hypothyroidism in green, pneumonitis in blue, and colitis in red, where the dashed line represents the median incidence rate. As shown, the first diagnosed adrenal insufficiency in our data set was recorded close to 50 days after treatment initiation. And thus, our goal is to predict both early and later onset IRAEs. Our primary goal was to predict which patients were at risk for developing an IRAE using symptom trajectory. Borrowing from the field of psychiatry, we use the term symptomics to refer to the study of individual symptoms. We brought symptomics into our modeling efforts so that we could identify which individual or constellation of symptoms leading up to an AE are more predictive or sentinel. This has important implications for individualizing therapy to minimize toxicity. We included all patients on immunotherapy in this study. We created separate models for each IRAE. We used elastic net regression, where the input was the area under curve for each symptom, and the output was the grade of IRAE. To evaluate results, we computed error estimates for each model. We included symptoms that occurred only up to the initial diagnosis of the IRAE. We incorporated grade and duration of each symptom, and we computed models 4 to 12 weeks after treatment initiation. We calculated a symptom burden score by multiplying grade of event by duration and computed an area under curve to reflect an overall symptom burden. Examining the IRAEs that we were powered to do the analysis for, which included hypothyroidism and adrenal insufficiency, from our model, we found that grade 2 or higher fatigue, grade 2 or higher headache, and grade 1 or higher shortness of breath were associated with subsequent diagnosis of hypothyroidism. The most predictive time point was at 6 weeks. This plot shows the symptom trajectory out to 20 weeks for patients in pink that developed hypothyroidism and in teal that did not develop hypothyroidism, where the x-axis is the number of weeks after treatment initiation and the y-axis is the proportion of patients with and without the AE. The early symptoms that were associated with adrenal insufficiency included grade 2 or higher fatigue, grade 1 or higher shortness of breath, grade 2 or higher decreased appetite, and grade 1 or higher diarrhea. Then we looked at what other symptoms were co-present in the affected population up until 6 weeks. Here, in this circular plot, each ring represents a single patient, and each wedge is a single symptom. These circular plots are meant to provide a visualization so that we can see what the co-occurring symptoms are associated with an AE. For both hypothyroidism and adrenal insufficiency, the most common symptom was diarrhea, as shown by the arrows. For hypothyroidism, diarrhea, rash, dizziness, fatigue, shortness of breath, and headache appear together at 6 weeks. For adrenal insufficiency, co-occurring symptoms included diarrhea, headache, and fatigue. Even though, overall, we had less patients in the adrenal insufficiency group, there was a higher density of shortness of breath in this patient cohort. And when we removed these symptoms from the model, our model significantly underperformed. Thus, a further predictive understanding of the constellation of these symptoms will help us monitor patients more closely, intervene earlier, and may help prevent full-blown disease from occurring. While CTCAE allows us to capture more standardized adverse event data across patients, as assessed by physicians, PRO provides a reflection of the symptom burden of treatment as experienced by patients. And thus, we are also evaluating PROs, both quality of life and adverse events in I-SPY. Collecting both types of information allows us to evaluate symptoms and their impact on quality of life. And so, for example, joint and muscle pain at week 4 was most predictive of reduced quality of life at week 12. And we have a more further and fine-grained PRO analyses that was presented in our poster yesterday. In conclusion, early onset of symptoms may predict subsequent risks for IRAEs. Understanding the risk factors for developing an IRE will help to optimize surveillance and potential treatment modification to minimize the impact of toxicity. Further confirmation of this model is required. We're building more interpretable classification algorithms looking at this data. We are analyzing PROs, and we have a grant to analyze genetic predictors to identify who is at risk of developing a severe IRAE. We thank the remarkable and very brave patients and families, our amazing patient advocates, all of the investigators, staff, and our DSMB for supporting the trial. We also thank all of our participating organizations and the Quantum Leap Healthcare Collaborative for sponsoring the trial. And lastly, I'd like to particularly thank Drs. Michelle Melisco, Dr. Dawn Hirschman, Dr. Hope Rugo, and the PI of the I-SPY trial, Dr. Laura Esserman. Thank you.
Thank you, Dr. Basu, for your presentation. I have a quick question for you. Your definition for hyperthyroid, which is you make your threshold, can you actually see that progressing from a subclinical state? And what is your threshold for defining as a hyperthyroid? Because that seems to be fairly predictive.
Yeah, so we used the CTCAE structure or adverse event nomenclature to define that.
We have a question on number 2.
Sykov from Rhode Island. I want to thank you for a very interesting and important analysis. As we're increasing the use of immunotherapy in our patients in the neoadjuvant as well as in the advanced breast cancer setting, detecting and diagnosing immune-related adverse events as early as possible becomes important. The problem is, are we aware of any ability to intervene, to discontinue treatment, or in some other way make a change to prevent hypothyroidism or adrenal insufficiency in patients who are developing symptoms suggesting its onset?
Yeah, that's why we're building these models. This was really a first step in doing that. We're also incorporating patient-reported outcomes. We think this would be a great and a true reflection of what patients are actually experiencing. So we hope that doing this kind of analysis, looking at those constellation of symptoms so we can really intervene earlier in the treatment process.
We'll take one last question from number 5.
Vogel, New York, very nice paper. So these immune drugs scare me a lot. And I draw bloods on every patient every week for the first 6 months looking for adrenal insufficiency, hypothyroidism, and diabetes. How much earlier could you pick it up by the symptoms than you could by a blood draw? In the United States, where blood draws are common and no one gives us a hard time about doing it, should we bother asking the patient? I ask the patient anyway. But will this pick it up earlier than a blood draw for a TSH a cortisol and an ACTH.
Yeah, and we're also doing earlier lab workups. We're doing cortisol monitoring that's been starting earlier. And we think that, I mean, as we saw in the data, even as early as 6 weeks, and with more data, that could be even earlier. We think that these models can actually really identify when patients are developing these symptoms. And then also, we think that the genetic polymorphism, the work that we're doing in the germline, can also add to the predictive power of these algorithms.
So, were you able to identify incipient disease before any laboratory abnormality?
I wouldn't be able to answer that, but my colleagues, Dr. Rugo and others here, would be the best people to answer that.
All right, thank you. Thank you, Dr. Basu, for your presentation. We're going to move on to our next presenter.